Hey everybody, Kevin McFarland here from the Art of Emergency Nursing. And about a month or so ago, we did a online learning on pediatric IVs for the non-peds nurse. Now I told everybody that I was going to get a replay of this presentation up on the web so they can go back and review it again if they'd like or share it with whoever they wanted to. And I tried and I failed. So here we are, we're going to go ahead and tape this thing again. Now, in case we haven't met, my name's Kevin McFarland, and like I said, I'm the host of a podcast called The Art of Emergency Nursing. You can subscribe to that podcast right here, and we'll go ahead and put a link right there. You can subscribe there. So subscribe, listen to the podcast. You're going to love it. If you're an emergency nurse, or if you want to be an emergency nurse, you're going to love that podcast. Now, I know you're thinking, why should I listen to this fool about starting pediatric IVs? And I'll tell you why. Because I have over 20 years of emergency medicine under my belt and about 15 years as an emergency nurse. I started as a pediatric ER nurse and then went on to adult and did some other things, but I'll always be an ER nurse in my heart. So we're going to do a little presentation on how to do peds IVs, because if you're not a pediatric ER nurse, maybe peds IVs are a little bit of a challenge for you. Well, I got you covered. I'm going to help you out. We're going to make that a little bit easier for you. So let's get into the presentation, shall we? Again, talking about peds IVs for the non-peds nurse, and we're going to try to make you feel more comfortable about getting those difficult pediatric IV sticks. Now, one of the first questions I like to ask everybody is, are you good at IVs? Hopefully you are. Hopefully you're pretty good. There's nothing like the feeling of being that go-to person. Now, if your patients all look like this, then we're all going to be really good at IVs. Now, of course, those of you who know me know that I took this picture of my arm for this video. Okay, not really. It's not really me. But you know what? If all my patients look like this, boy, my IV skills, my IV success to miss ratio would go way, way, way up. But in reality, Murphy's Law takes over in the emergency department. You know Murphy's king. And typically my patients look more like this. Or maybe they look like this. Now, that's going to be a difficult IV. That's not the IV you're going to get in the first stick. Well, maybe you will. Hopefully you do. But what about pediatric IVs? Pediatric IVs tend not to look quite as bad as those two you've seen, but sometimes they do. Can you imagine this little kiddo coming into your emergency department and needing an IV? Forget it. This little kiddo is going to make you run. This kid's got wrinkles on his wrinkles. Now, what we know about pediatric IVs is that low exposure equals low confidence. So if it's not something you do all the time, it's going to make it a little bit more difficult to do. And that's why we're going to be here to help you today. Because I know that unless you do a lot of peds IVs, you may be kind of challenged with it. Now, let's talk about IVs in general. And most studies say that IVs have anywhere from a 10% to a 40% failure rate, meaning we don't get it, healthcare workers don't get it on the first try. Now, that's a pretty broad number, but it's also a pretty bad number. Now, when we look at pediatric success rates, those numbers can really be different too. For most nurses, they say that most nurses are about 40% success rate on peds IVs. They say there's about 44% success rate on IVs in pediatric patients. That number goes up a little bit if you're an IV nurse, if you're maybe a PICC line nurse, maybe you're the IV team for your hospital. That number goes up to about 98%. Again, these are probably your most skilled providers. And they say it's about 23% for our physicians. Now, I'm not dogging our physicians. I know a handful of physicians that can start IVs phenomenally. But by far most don't. Most, again, it comes down to that. It comes down to how often they do it and how comfortable they are with it. And most physicians aren't starting a whole lot of IVs. So you got to ask yourself first the question, how many attempts do you do before you move on? Now, I'll tell you that my kind of rule of thumb is typically I get 2 shots to get the IV. And if I don't get that IV in 2 shots, I'm out. I'm done. I'm going to step aside and I'm going to let someone else give it a shot. Now, one of the things that's really important when we're talking about pediatric IVs and just IVs in general is don't go in there with a big head and think that you're the only one who can get it. A lot of times, people with more experience than me, less experience than me, sometimes if I miss it, sometimes they're having a good day, maybe they'll get it. I limit myself to 2 pokes, and it depends. If I'm not seeing a whole lot and I try one and I don't get it, sometimes I'll just step away and let somebody else do it. Now, there's other times where I got to look around and go, sorry, kid, I'm your best hope, dude. We're going to go ahead and try this again. And you can do that if there's a reason you have to do that. But if there's other skilled providers there, let them give it a shot. Most studies show that people will go anywhere from 1 to 10 attempts on an IV. Now, if you're the nurse that does 10 attempts on a patient, any patient, to get an IV, I want you to take yourself out back, slap yourself in the face, and tell you to stop doing that. Because nobody should be poked 10 times before you go and get help. There's nothing worse than going to a patient where someone says, hey, we have a difficult IV, will you come give it a try? And they've used up all the great shots that you might have been able to get had they just called you a little bit sooner. So don't be that nurse. Don't be that guy. Don't be that gal. Nobody likes that girl. Now, vascular access is often required in pediatric emergencies. A lot of times when kids come into the emergency department, you know when they look sick, you know they're going to need an IV. We're going to talk a little bit about when they look sick. We're going to use something called the Pediatric Assessment Triangle to evaluate our children right from the get-go. And the Pediatric Assessment Triangle, if you're not familiar with it, is using the pediatric ABCs. Now, they're slightly different from the ABCs that you might know. In this case, we say A is for appearance. Sick kids look sick. And I'm going to show you some pictures here in a little while of a kid who looks sick. Now, if they look sick, they probably are. Now, then we take airway and breathing and we combine them over with the B in the pediatric ABCs, and we evaluate the breathing. We're going to evaluate the rate, the depth, the effectiveness of every breath, and whether or not their airway's open. And then the C stands for circulation or skin color. We're going to look at their skin color. We're going to look at their cap refill. That quick across the room assessment is going to give you a lot of information about your pediatric patients. Now, we still need to do a full assessment. We'll do that later, but this will at least get us started. Now, let's talk a little bit about vital signs. Now, I have a small brain and I have a hard time remembering lots of things. So I try not to try to remember pediatric vital signs. They're a little bit different and they vary by age. So it makes it kind of hard to remember. What I always recommend to people is get yourself a little badge buddy. Get yourself a little something you can wear on your badge that gives you all those vital signs right from the get-go. Or carry a reference material, do something that's going to give you an idea of where those kids are in their vital signs. Don't trust that your brain's going to remember all that. Now, here's the number that I like to tell people to kind of keep in mind. For school-age children, if their heart rate is above 120, that child might be in trouble. Everything else from about 120 up, if their heart rate's above 120, for most kids, then I know that that patient's in trouble. Now, for infants, we'll give them a little bit more leeway besides the 120. We can get them up to 160, and that might be okay. But above 160, we know that child's in trouble. So those are children that we know we need to watch very, very closely. Now, let's talk about the respiratory rate real quick. Again, respiratory rate's going to vary by age. It's going to vary by age. And what I always tell people is when you're assessing a respiratory rate of a child, one, you actually have to count for a full minute. They have variability in their respiratory rate, and a lot of times they'll kind of slow down a little bit, and then they might kind of kick back up and go fast again. So you should really listen for a full minute. How I recommend doing that is take your stethoscope, put them in your ears, put that stethoscope right on their lungs, pull your watch up like this, and actually count those respiratory rate. Count that respiratory rate right from listening on your stethoscope. Don't just try to watch their tummy. Put the stethoscope on, hear every breath sound. I like to close my eyes, listen to the breath sounds for a couple minutes, make sure I'm hearing them, and then I start watching the respiratory rate using my watch and counting along. It's the best way to get pediatric respiratory rate. Now again, I can't emphasize enough the importance of actually counting the respiratory rate. I'll never forget when I was a pediatric ER nurse, we had a regular ER nurse, an adult ER nurse that came to help us out in the peds ER. She was in triage, and I'll never forget that she did vital signs on a child, on a little infant, and she brought the chart back. And the chart at the time, our triage notes were paper, and the respiratory rate said 16. Now, do you think she counted those respirations? I don't think she counted those respirations. And we asked her, we're like, hey, are you sure about these respiratory rate? She said, oh, let me go count it again. Maybe I got that wrong. And we're like, gosh, I hope so. Because if they're not, if they truly are 16 and they're an infant, then we need to get them out of the waiting room and into the emergency department. Now, let's talk just briefly about blood pressure. I'm not going to spend a lot of time on this. Blood pressure kind of comes and goes about being in vogue with children. Again, it's kind of back. It's not super important, but what is important is if you're going to get the blood pressure, if you're going to take the time to do a blood pressure, make sure you use the right cuff. If you're not using the right cuff, that's not an accurate blood pressure at all. So make sure you use the right cuff. If you do use the right cuff, then go ahead and document your blood pressure. If not, just skip it. Now let's talk a little bit about dehydration. Dehydration, a lot of times, is caused by virals. It can be caused by a viral infection. Usually includes a fever, maybe some diarrhea, maybe some vomiting, maybe they have decreased POs. But all those things can cause children to get dehydrated, and they get dehydrated in a hurry. And when they get dehydrated, they look terrible. Now, dehydration can also be caused by more serious infections like bacteria, Salmonella, E. coli. There are a couple of real popular ones. Or it could be something involved in, like, for instance, urination. Like maybe they're a diabetic and they're peeing out all their fluids. If that's the case, that's going to lead to dehydration. Now, what do we see when we see dehydration in children? We see really sick-looking kids, really puny-looking little kids. They may have very sunken eyes. They may have decreased frequency in urination. They may have less wet diapers than they normally do. You got to ask mom and dad about how many wet diapers. If they're crying with no tears, it may be due to dehydration. They may be very irritable, and they may be a little bit lethargic. Now, let's just take a minute and talk about lethargic, because lethargic in my mind is a bad word. When I think lethargic, I think a child that looks like this. I think a child that looks sick and looks like they're on death's doorknob. That's what I think about when I think about a lethargic child. I don't think about somnolent. I don't think about sleepy. I don't think about irritable. I think about limp baby when I think about lethargy. So if you hear lethargic baby, that's what you should be thinking too. Now let's talk a little bit about fluids. There's not a whole lot that I'm going to ask you to remember, but this is one of the things probably worth remembering, is that the bolus rate for children, for pediatric patients, is 20 cc's per kilo. 20 cc's per kilo, your fluid of choice, either normal saline or lactated bringers, but that's it. No additives and that stuff. Not typically, not to start unless the doctor orders that specially. But most of the time, it's just going to be normal saline or lactated bringers. And you're going to put in usually over about 10 to 15 minutes and repeating again every 10 to 15 minutes as needed to get that bolus in. Again, 20 cc's per kilo. That's the magic number. Now, where are you going to go to get that IV? There's a lot of places you can go with your pediatric patients. This little chart has a couple of them here. I'm a big fan. My first preference and the first place I look for most infants, for instance, is in the hand. The hand is where I'm going to typically look first. I'm going to go there first and see what I can find and see if I can find something there. My second choice may be the AC. The AC, a lot of times if they have chubby little arms, is going to be a little bit tougher to get than would be the top of the hand. Other places to look, you can definitely look at the legs, look at the feet. One of my friend's favorite was the great saphenous down on the medial part of the leg. All those are options where you can get a pediatric IV. EJs, not as common in pediatric patients, but certainly is an option. And then, of course, scalps as well. All these little points where you see dots. Now, in your newborns and your brand new babies, once you cut that, if you're to deliver a baby and you cut that umbilical cord, a fresh cut of the umbilical cord is going to have an artery and two veins in the umbilical cord. In that umbilical cord, you can actually thread a catheter into one of the two veins on that patient. Certainly, that's not something most nurses are going to be comfortable with. That's something you'd have your doctor do, and certainly probably wouldn't happen in like the pre-hospital setting. Now, again, upper extremity. My first place to go is the hands. That's a great place to go for chubby little infants. Now, if you're like me and I'm a go by feel kind of IV person, you may not be able to get this just by feel on the top of the hands. Sometimes you can't feel that, but what you're going to see is you're going to see a faint little blue line that you'll see on the patient's hand. That's what you're going for. Again, I already mentioned the great saphenous. It's a great place in the lower leg if you're looking for a place to start an IV on a child there. Let's talk just quickly about scalps. Scalps are really tough to stick. Okay? They're tough to stick, they're tough to secure, and most importantly, they just freak the families out. If you're starting an IV on a child and you're starting an IV on their head, that's going to freak out the family. You just need to know and be ready for that. Explain to them what you're going to do. Give them lots of heads up. Let them know exactly what the plan is and why you're doing it if you're going to get a scalp IV. Now, if you're going to get a scalp IV, it's really important. Tourniquet placement is really important. Here are some of the areas on the scalp where you might be able to get a vessel. Right here in the scalp, just in front of the ear, just above the eye, is some place where you may be able to find a very small, faint vessel on those infants. Now, I mentioned tourniquet placement. Tourniquet placement doesn't go around the neck. Very, very important. But what it does is it goes around the head. And what little pro tip I learned a long time ago to put a little rubber band around their head to help kind of engorge those veins. And you can see in this presentation, you can see in this picture how effective that works. Look at that little vein right there. You might be able to cannulate that. Okay? Now, I learned the rubber band trick a long time ago. Hopefully you know that too. I'm going to give you a little pro tip though. And is if you take a little piece of tape, like this one here, and you put a little piece of tape on your rubber band, it's going to make it a lot easier to get that rubber band off without snapping that kiddo in the head. Because you don't want to snap the kiddo in the head. Looks bad for the parents. Parents hate that. If they're greater than 9 months, probably to be avoided. It usually just doesn't work out as well once they get that old. If they have any kind of head injury or any kind of ventricular shunt, you're probably going to want to stay away from it. Now, let's talk a little bit about the equipment. Now, here are your different angiocats, your different sizes. Yours may vary depending on the manufacturer. These are the ones that I used to work with a long time ago. And they're pretty standard. The colors are standard, and the drip rates typically tend to be standard as well. Now keep in mind that a lot of people will tell you go big or go home, and that's not always the case with pediatric IVs. With pediatric IVs, understand small is good, and any port in a storm. I always tell people I'd rather you get a 20 gauge on an adult than try to fight to put a 14 gauge in. I can get everything I need through a 20. I can give blood through the 20, though it's not optimal. Certainly maybe can't rapidly transfuse through a 20, but I can do just about everything else. For our pediatric patients, we're going to use maybe 22s, maybe 20s for some of their school-age children, or you may use a 24, and a 24 is a pretty small needle. Now, one thing I didn't include, because it's not super common, is 26 gauge angiocats. And there are 26 gauge angiocats out there. They are teeny, teeny, tiny, and they're very, very expensive. So a lot of ERs don't even bother carrying them. Now, one thing I'll tell you is that for any pediatric patients should never be on a free-flowing IV. Never, ever, 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 ever. If they're going to be on IV, if they're going to be on IV, ideally they should be on a pump. If they're not going to be on a pump and you just need to put fluids in, then what I would suggest is using the Volutrol that you see here, the Volutrol or the Buretrol, and that gives you a graduated cylinder that gives you an exact amount of fluids to give that child. Never, ever, ever free-flowing IVs on pediatric patients. Now let's talk about the zen of pediatric IVs. You got to stay calm and you got to stay focused. That is critical in any kind of pediatric IV. The other thing you need to know is that you may have to immobilize the extremity or you may have to immobilize the whole child. Now, in every pediatric emergency department I've worked at, we always made pediatric IVs a team sport. Now, there are some nurses that were good enough to go in there and do it by themselves, where they were holding and then getting the IV. But what I find is that's not as reliable as getting a good pair of hands, a good holder, a good helper. Makes all the difference in your IV success in the world. All right, here we go. Now, I said that I typically go by feel, but we're going to start our looking process. I typically start I'll pick one extremity and I'll start at the hands and work my way up. I like to feel for adults, but I know with pediatric patients, sometimes I'm not going to be able to feel it. It's not going to feel like that round, squishy vein we sometimes feel with adults. But what it's going to feel like is maybe a little indentation in the tissue. Okay? And typically that's where you may see a little thin blue line. That's what you're going for. All right. We've picked our place. We found our ideal site. And now we're ready to rumble. This is an old setup. Your setup may vary. It's probably going to look different. But this give you kind of an idea. One of the things I'll tell you is if you're going to start an IV, definitely draw blood. If the kid looks sick at all, then you're going to go ahead and get cultures as well. Try to get those in and get out of the way. That way you can go in there and get started on this IV. Now, let's talk a little bit about the steps of a successful pediatric venous access. You need to prepare the family, prepare the child for the procedure. Do they stay or do they go? And that depends on the parents. If they're pretty legit, they're smart parents, or if they're being helpful, go ahead and consider letting them stay. If they're a little on the hysterical side, or if you can see that they're actually escalating the child, then you may ask them to step out if that's what's going to be best for the child. You need to not only gain trust with the family, or gain trust with the patient, you need to gain trust with the family as well. And sometimes that can be really difficult. Now, one thing that will absolutely kill your trust is never, ever, ever lie. Never, ever, 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 ever lie to the patient about the painfulness of the stick. You can't say it's not going to hurt. You can't say you're not going to feel a thing, because they're going to feel something. You would feel something anytime someone sticks a needle in your skin. You're going to feel it, but you're going to be okay. And you just never lie and tell them it's not going to hurt. You say it just hurts for just a second, split second, then we're done. Now again, I'm a big fan for looking at everything before you decide to decide where you're going to go. Look at the left arm. I don't know how many times I would look at the left arm, see something, be like, okay, that's my jam. That's what I'm going to go for. I'd start the IV, and then sure enough, it would blow or whatever would happen. I'd look at the right arm, and I'd be like, oh my God, there's an amazing one right there. That if I would have just looked at all the extremities, I would have been able to do the right the first time and just been done. So look at everything before you start going for the IV. Consider getting the non-dominant hand if at all possible. That just makes it more convenient for our friends up in the med-surg area. All right, it's time. It's time for the rubber to meet the road, and it's time for us to get that IV. Now, like I said, I'm a big fan of having pediatric IVs be a team sport. I always say bring in help, have holding help, have them ready to go, and that's going to make all the difference in the world. Let's talk about the poke real quick. So, again, you're going to have to immobilize the child, immobilize the limb for sure, maybe immobilize the whole child. That's sometimes the right way to go. But look at this picture. There's a couple things that should get your attention with this picture. One, the thing that probably first got your attention is the fact that this person isn't wearing gloves. Pediatric IV nurses sometimes bad about the IV thing. And what I have to say is, if you can't start the IV with gloves on, then you can't start the IV. PZR nurses, do you want to argue with me? They're sometimes the worst. Now, I love you. It's important. I know they're just kids and they're probably not sick, but you're protecting yourself and you're protecting the patient. You can't start the IV with the gloves on. You can't start the IV. It's just the way it is. All right, I'll get off my soapbox. You may not be able to feel the veins. You may have to look for the veins. And I said already that I'm one of those that goes mostly by feel. But again, that may not work here. You may have to use your eyes on this one. You have to know your anatomy. You have to know your anatomy and know about kind of where the veins probably should be. And again, we already talked about universal precautions. You got to wear the gloves, okay? And then again, good site prep. For site preparation, it depends on your institution's policy. You're going to go with whatever your organization uses. Betadine has kind of fallen out of favor. Alcohol is still very commonly used. Sometimes you'll have a little 2x2 or like a little ChloraPrep. ChloraPrep works great. I think about 5 months is the cut for ChloraPrep, that anything younger than 5 months is a no on the ChloraPrep. I'm not sure. I'll put a little note here on the video once I verify that. Now, when you're doing your insertion, you're going to need a lower angle of insertion than you normally do for most of your adult patients. You're going to use multiple hands to stabilize the limbs, yours and other people. Now, one of the things I showed you in that first picture where you didn't have the gloves is I showed you this grip. And this grip, if you can imagine getting the child's hands and holding the hand down like this, to where you're bringing the fingers to the wrist just like this, and that really isolates the top of the hand. That's my favorite hold for doing a pediatric IV. Fingers down, touching the wrist if possible, and then that really isolates that flat part of the hand. A great way to see the top of the palm or top of the hand, and a great place to get IVs on kids. You're going to use a lower angle of insertion. Sometimes what you need to do is you need to turn the child's head away, turn them away from the stick, because sometimes anticipation is most of the pain. Turn their head away the best they can. Let them know when they're going to get poked. And again, never, ever, ever, ever lie about the poke not hurting. Then, once you get the IV in, you got to see if you're getting blood return. Now, sometimes those very small catheters, it takes a little bit for some blood to come. You may get it just a drop or two in your flash chamber. It may not be filling the flash chamber like you're used to with your adults, if you're used to doing adult IVs. Sometimes what you'll have to do, sometimes if you're not getting much of a flush, you may have to give that or getting much of a return, you may give that a little bit of flush with about 3 cc's of normal saline to check for patency. If you need to do that, that's fine. Just make sure you pull that back out if you need to draw blood as part of what you're doing. And here in this picture, you'll see that the blood is coming right there into the tube as it's just kind of starting to creep up. And then you know that is indeed a successful IV. Now again, look at the way that this hand is gripped here. This hand is gripped to where the top of the hand is absolutely isolated, and with enough little bit of pressure, you can really put that elbow down into the bed and really secure that limb very, very well. Now, if this is a really squirmy kid, they may need somebody else to help kind of hold the rest of the child. As soon as you get it in, it's critical that you try to start taping that IV down just as quickly as you possibly can. Tape, and more tape. Use a Tegaderm, use tape, use whatever your facility requires. But you're going to want to secure that IV as quickly and as thoroughly as possible. Now, I'm a big fan for just taping the snot out of stuff. Now, if for some reason, like in this picture, or if you need to use an arm board on the child, like you see in this picture here, tape up your IV first, get that nice and secure, then put on your arm board and secure your arm board to the patient's arm. Again, outside of the tape that you have actually securing the IV. That way, if you need to take off the arm board for some reason, you don't need to take down your complete dressing, and then you have it separate. Great little pro tip for you. Now, the catheter has to be removed if there's any pain at the site, if there's any edema at the site, if for some reason the IV is not flowing, or if there's any kind of fluid coming out of the IV, like if it's leaking into the tissues, the IV's got to come out. Okay? You need to know that it's in. You need to know that it's flowing well. If it's blowing up but still running, it still needs to come out. Those IVs need to come out as quickly as possible. The last thing you want to do is run a bunch of fluids in there. The last thing you want to do is run a bunch of fluids in there and then find out that you actually have a bad IV. So as soon as you get the IV, you're going to want to get your bolus started, get your fluids hooked up if that's what you're there to do. Get your fluids hooked up. And then as soon as you can, get the baby back to mom and dad. Let them be the heroes. You've already been the bad guy. You've done the dirty part. You got the stick. You got your blood. Get them back to mom. Get them back to mom and dad's arms just as quickly as you possibly can. And that's going to make them feel better. All right, let's talk just a little bit about pain. We know that this is a painful procedure. And again, we already talked about never lying to the child about that pain. But what you can do is you can reward the child. A great reward is stickers. Kids love stickers. They'll do just about anything if you offer them a sticker. Stuffed animals, another great option. Again, one of the things I do during the IV is a lot of times I'll use distraction techniques, talk about toys, talk about their pets, talk about their family, ask them questions, keep them distraction. Distraction techniques is really, really critical. In one pediatric one pediatric emergency department I worked in, we had a child life specialist who would oftentimes come in there, and they were a pretty good holder, but they were really good at distracting the child. They'd have an iPad, maybe some bubbles or something to distract the child. Now, don't do this. Don't give the child the glove balloon animals. Okay? This was a big no-no in a pediatric emergency department I worked at for a long time. This is a big no-no. If they came in via EMS with a balloon animal like this, we'd take it immediately and swap it out with a toy. Because what we don't want them to do is we don't want them to have this balloon. This balloon is a choking hazard, like any balloon with children. Balloons and children just don't go together. They're a choking hazard. Kids put everything in their mouth. They're going to put this in their mouth and they're going to start chewing on this thing. If it pops and gets in their airway, that could be a hell of an airway obstruction. So absolutely no balloon animals. All right. So you've done your IV. Maybe it worked. Maybe it didn't. Maybe if you're not so lucky, maybe then you need to go with your big guns. For me, for our pediatric patients, when we talk about the big guns, we're talking about IOs. Now, the PALS book recommends that an IO be tried if you've tried 3 standard IV attempts peripherally with no success, and the child's unstable in need of either drugs or fluids. If they're unconscious or unresponsive, again, a little bit higher in your thought process to go right to the IO. Okay? If you don't think you can get an IV and the child's gravely ill, like needs meds, needs ACLS interventions, just go straight for the IO. Skip the peripherals, go straight for the IO. It's quick. It's easier now, easier than ever before, and it's absolutely effective. Now, if you remember back in the day, we had 2 different manual IO needles. We had the Cook Critical Care needle, this little needle here that looks like an owl, and you would have to actually just kind of, you kind of hold this thing, and you just kind of wiggle it in, just kind of twist and twist and twist and shimmy until you actually go through the bone. Now, that's as horrible as it sounds. But the Cook Critical Care needle always felt like I was sticking somebody with something bad. Now, the other option was the Jamshidi, a lot more popular, used a lot more often, I think, than the Cook Critical Care. But you can tell me in the comments which ones you guys used when you had the manual IVs, or the manual IOs. We always had the Jamshidis. And the Jamshidis, again, they're a big needle. They're a big needle, and they would go right into the bone of children. Now, do you remember the signs of a successful IO? You need to make sure that your IO is actually in. Do you remember the signs? I'm going to give you a minute. Hopefully you do. Hopefully what you're saying is you're saying, Kevin, I know that a successful IO is going to stand on its own. I know that it's going to flow well. And I know that there's going to be no pain or swelling at the site. Now, what about aspiration? Sometimes aspiration works, and sometimes it just doesn't. So don't hang your hat on aspiration. If it stands on its own, it flows well, and there's no swelling at the site, then by golly, you got yourself a successful IO. Now, some of the newer toys, some of these newer toys for IOs are more popular now, and it's opened up IO to where we can now use it in the adult population as well. There's two of the most common IO devices. One of them is what's called the BIG, or the bone injection gun. This one is that orange one there that looks like a gun, and what you would do is you'd hold it up and it was like a pop. You'd push it down and pop the needle in by pneumatic pressure. Now, that one probably wasn't near as popular as the Easy IO. The Easy IO is a little bit, to me, a little bit more sophisticated. It's a little drill, and you hook the needle to the little drill, and then zzz, you can just drill it right in. And for adults, we can go right there into the shoulder and just drill it right in, and they work really, really well. They work great for adults, and they're still great for children. Certainly an option if you need it. Speaking of toys, these things here are what's called a venolight. And the venolight is a little light that basically illuminates the skin around the IV, around the vessel, so you can see if you can actually get that IV. Let me show you what it looks like. You can see here the glowing orange illuminates the tissue around the vessel, and that vessel is going to be a little bit darker, so you can actually go ahead and try to thread that catheter into the vessel. Now, I've tried these a couple times. They're okay. They work kinda. They certainly don't work on everybody, but certainly it'll at least get you a little bit closer if you have nothing else. I've seen people use these, and I've also seen the pediatric ER nurses at a hospital I worked at would sometimes use a red infrared flashlight, and they'd hold it up against the skin, the surface of the skin, or actually put it, for instance, with a neonate, they would actually put it on the palm side. They'd put it on the palm side of the hand and shine it through the top side of the hand. Now, be careful with these because these things do get warm, so you got to really make sure that you're not burning that child with these LED lights. The LED lights are cool. They usually don't, but with those flashlights, sometimes they get a little warm. Another little toy I want to talk to you just briefly about is what's called the AccuVein. And the AccuVein, essentially what you're seeing here, it illuminates the vein. It illuminates the tissue around the vein, and the vein stays a little bit darker, so it actually kind of stands out. Now, the old ones were red. The newer ones are green. They look like a green kind of bright light color. We had these in the first pediatric ER I worked in, and they made 3 really great coat racks. We never ever used them. We never used them at all. Later in my career, I was at a hospital where they used them quite frequently because they didn't have access to ultrasound. And sometimes if the nurses couldn't get an IV, they would go ahead and try the AccuVein. And they got really good at it. Those nurses were really good at the AccuVein. It took me some practice, but I had the opportunity to practice at this organization because there was nothing else. If I couldn't get the IV, I had to try something. And the AccuVein is typically what we would try. Now, I mentioned ultrasound-guided IVs because that for some organizations is an option. Some organizations will let their nurses do it. Some let their physicians do it. It just depends on your organization. Now, here's the trick with ultrasound-guided IVs. Very effective. Great way to find the vessel, cannulate the vessel. It works really, really well. I worked at a hospital where we taught the technicians to do this, and some of our technicians were absolutely amazing at this skill. But it is a skill. You have to take what you see in a 3D world, a 2D world on that computer screen, and you have to process it in your brain and actually use it to guide your needle in the 3D world. So if you're really good at video games, that's probably really easy for you. I struggled a little bit with this. I had a little bit of a hard time with ultrasound guided IVs. It didn't work super great for me, but it was cool to practice. Now, something that I've done a little bit of research on, but I wanted to share with you because maybe you've heard of it, maybe you haven't. And it's this stuff called Hylenex. And what Hylenex does is Hylenex facilitates subcutaneous fluid infusion. So if you've ever gone to the vet and you've seen them not bother getting an IV on the vet, but what they do is they take the needle, and sometimes they'll put the needle just right underneath the skin, and they would do subcutaneous fluid infusion on pets. They'd infuse a little bit of fluid right in, like sometimes up in the back, right behind their shoulders, and then let it diffuse into the vascular system that way. And you know what? It works. It works well on pets, and it actually works on humans too. Now, our subcutaneous infusion, that uptake of the fluids in the subcutaneous tissue, isn't as effective as it could be, so that's what Hylenex does. Hylenex makes the subcutaneous tissue more apt to bring in that fluid. So they would use this on mildly to moderately dehydrated children and infants. And basically what you would do is you'd take a little catheter, you'd put it, the literature I read said that you put it right between their shoulders so that they can't reach it. And it's this little tiny needle that just goes into the subcutaneous tissue. You put in a little bit of the Hylenex, you treat them with a little bit of the Hylenex, that entire vial there, and then that would actually help facilitate about 150 cc's of fluid, or is it 1500 cc's? I'm going to double check that. But here is some pictures of what the manufacturer did and some of the studies they did. What they found was the ones on your right are without Hylenex, with just bringing subcutaneous fluid into the subcutaneous space and letting it absorb. And again, it works. It works on people without the Hylenex, but with the Hylenex, it happens much more rapidly. You don't have the localized swelling that you do if you were to just do it subcutaneous on a human. Again, sometimes they'd recommend that either the anterior or lateral aspects of the thighs or up in the scapular region is the place. And they were finding infusion rates of about 383, give or take, depending on a lot of different factors. But they would find pretty good infusion rates for this. So this was being studied at one of the hospitals I worked at. I haven't heard a whole lot about this. I hope they're still working on perfecting this, because this would be a great way to get fluids on children. Now I'm going to ask you to put down in the comments, what are your tips and tricks to a successful pediatric IV? I'm going to ask you to leave in your comments your favorite tips or tricks for starting a pediatric IV. I want to see those down below. That way I can share them on my next video. Again, thanks for listening. My name is Kevin McFarland. I'm the host of a podcast called The Art of Emergency Nursing. And I appreciate you being here, and I appreciate you listening to me. Thanks for your time. This presentation was initially done as a thank you for all the people who are working on the front lines of the COVID crisis. So if that's you, thank you so much. Your patients thank you, your team thanks you, and I thank you. Thanks for all the hard work you're doing on the front lines. We really, really appreciate you. Thanks for listening. I hope you got some value out of this. If you did, hit subscribe to my channel, subscribe to my YouTube channel. I'll be doing more videos just like this, so definitely hit subscribe, and thank you for being here.